Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Voles. Today, we're talking about something that's quietly reshaping healthcare in Southern Oregon and across the country: the shift toward cash pay medicine and direct primary care. This isn't a fringe movement anymore. It's accelerating fast, and it's creating real consequences for the working middle, for safety net providers, and for how healthcare access functions in our region. Southern Oregon doesn't suffer from a lack of people who care about healthcare. We've got dedicated providers and community members who want the system to work. The problem is the system makes caring harder than it needs to be, and increasingly providers are opting out of that system entirely. So let's talk about what's happening, why it's happening, and what it means for Jackson County. According to a health affairs analysis, membership-based primary care, including concierge medicine and direct primary care, grew by 83% between 2018 and 2023. The number of clinicians working in these models increased by 78% over that same period. Another market analysis estimates there are approximately 2,688 DPC practices nationwide as of 2025, with continued growth. These aren't massive numbers relative to total primary care delivery, but the trend is unmistakable. Physicians are leaving traditional insurance-based practice for models where they get paid directly by patients through monthly membership fees rather than billing insurance. Why? The data is pretty clear. Nearly 43% of U.S. primary care physicians report feeling burned out, according to the American Medical Association's 2024 report. Administrative demands are cited as a major contributor, and we're facing significant primary care shortages nationally. Projections suggest gaps of approximately 40,000 primary care physicians by 2036 if current trends continue. Burnout and projected shortages affect the supply side of care delivery. They make membership-based and cash pay models more attractive for providers, but they also reduce capacity in traditional networks. When a primary care doctor switches to direct primary care, they typically shrink their panel from 2,000 plus patients to maybe 600. That's better for the patients in that DPC practice, but what happens to the other 1,400 people? Now, two major policy changes just made cash pay and DPC adoption much easier. First, federal changes. In 2025, Congress passed something called the One Big Beautiful Bill Act, OBBBA. This modified federal tax rules governing health savings accounts, permitting certain DPC arrangements to qualify as eligible HSA expenses. Under the new law, effective January 1st, 2026, HSA funds can be used to pay DPC membership fees, subject to limits: $150 per month for individuals, $300 per month for families. These limits adjust for inflation annually. This removes a long-standing financial barrier for individuals who combine high-deductible health plans with DPC memberships, effectively creating a tax-advantaged pathway into cash-pay primary care. Second, Oregon-specific changes. Oregon passed House Bill 2540 in 2025, effective January 1st, 2026. This requires most health insurers to credit direct payments made by enrollees, including DPC membership fees, toward annual deductibles and out-of-pocket maximums, as long as the services paid for are medically necessary and the cost is less than a comparable in-network charge. Think about what this means. Previously, if you paid for DPC out of pocket, that money didn't count toward your insurance deductible. You were essentially paying twice, once for DPC, once through insurance premiums, and getting no credit. Now, at least in Oregon, those DPC fees count. This policy change significantly reduces one of the key economic disincentives for cash pay arrangements. So we've got federal tax advantages for HSA users and Oregon law requiring deductible crediting. Both changes make DPC more financially viable for a broader swath of people. But here's the question: who actually benefits and what happens to everyone else? Let's talk about the working middle in Jackson County. Households earning too much to qualify for Medicaid or robust insurance subsidies, but not enough to comfortably afford rising commercial insurance costs. These households face a dilemma. Insurance is more expensive and less predictable. Deductibles and out-of-pocket exposure continue rising. Meaningful access to primary care via insurance networks is getting harder to secure. People in this category may turn to cash pay models to preserve primary care access, but this is only feasible for a subset with sufficient monthly disposable income. Let me walk through the math because the trade-offs are real. Option 1, high-deductible insurance plus direct primary care. A family of 4 might pay $300 to $450 monthly for a high-deductible health plan after subsidies, if any. DPC membership runs maybe $75 to $150 per adult per month. This adds up to $9,000 annually on the high end. What does this buy? Same-day or next-day primary care, predictable costs, reduced administrative friction, earlier intervention for minor or chronic issues. What it doesn't solve: specialty care costs, hospitalization risk, imaging procedures, oncology exposure. This is a primary care optimization strategy, not full healthcare coverage. Option 2, traditional insurance-only coverage, higher monthly premiums, opaque pricing, long wait times for primary and specialty care, frequent delays or denials. The paradox here is that many insured families in this tier are technically covered but functionally undertreated, delaying care until problems escalate, the most expensive outcome possible. Option 3, which is growing quietly, fully cash pay with minimal insurance. Now, provider panel shrinkage creates real local access problems. According to Oregon's 2025 Healthcare Workforce Needs Assessment, rural and remote areas have a primary care capacity insufficient to meet demand. This contrasts with urban areas where supply approximates demand. As clinicians opt out of insurance networks in Southern Oregon, those who cannot or choose not to join cash pay practices compete for fewer traditional appointments. Wait times increase. Unmet need grows. Direct primary care is simply the most visible edge of a much broader phenomenon. Across Southern Oregon and nationally, specialists are shifting to cash pay consults and procedures. Behavioral health providers are exiting insurance networks. Chiropractors, physical therapists, and integrative providers are increasingly cash only. The reasons are consistent across disciplines: low reimbursement rates, high administrative burden, delayed or denied payments, loss of clinical autonomy. This is not ideological, it's operational. Who actually benefits when providers opt out? Providers get more predictable income, smaller panels, lower burnout, higher job satisfaction. From a workforce perspective, cash pay models often retain clinicians who would otherwise leave practice entirely. That benefit is real. We don't want to lose providers from the system completely. Patients who can afford membership get better access, longer visits, improved satisfaction, earlier intervention. But this benefit is income gated. If you don't have the monthly disposable income for DPC fees, you don't receive these benefits. Insurers may benefit indirectly. fewer primary care claims, risk shifted back to patients, narrower networks normalized. What looks like consumer choice can also function as cost offloading, so are outcomes actually better in cash pay care? What the data supports: improved patient satisfaction, better chronic disease monitoring in primary care, reduced non urgent emergency department use in DPC populations. What the data does not yet prove: superior long term outcomes across populations, cost savings once specialty and hospital care are included, equity adjusted system wide benefit. In other words, cash pay models improve experience and access for those who can afford them. They do not, by themselves, fix healthcare affordability or population health. What could we do differently? Are there other solutions other than cash pay expansion that can address the same problems? Administrative reform. Administrative burden, prior authorizations, coding complexity, claims appeals, documentation requirements is a key driver of provider burnout and exits from insurance networks. Simplifying this could make staying in traditional networks more feasible. Colorado's alternative payment model alignment initiative makes it easier for doctors by getting different insurance companies to use the same rules for payments and paperwork. Oregon could pursue similar initiatives. Payment reform. Under fee-for-service, clinicians are paid for volume, number of visits, tests, procedures. This drives up overhead, adds complexity, and contributes to burnout. Better paths forward include value-based models. Medicare's ACO, Primary Care Flex model, gives doctors money upfront every month instead of making them wait to get paid for each individual visit. Medicare's Making Care Primary initiative is a long-term plan that helps smaller doctors' offices learn how to work better with specialists and community groups. It gives them the tools and extra support they need to make sure their patients stay healthy and get the right care at the right time. These show how payment can shift from bill for every service to invest in population health. Several states reimburse primary care at or above Medicare levels in their Medicaid programs. New Mexico, Montana, Alaska, Maryland, Vermont, Indiana, North Dakota, Wyoming, all reimburse at or above Medicare rates. Imagine a doctor's office is like a lemonade stand. If it costs the doctor $10 to see a patient, but the insurance only pays them $7, the doctor might have to close their doors or stop seeing those patients. By paying the full $10 or even $11, the state makes sure the doctor can pay their rent and keep their office open for everyone, instead of only helping people who can pay with cash. Middle-tier coverage options. One of the strongest pressures pushing patients into cash pay is that traditional commercial coverage often feels less accessible. High deductibles, narrow networks, long waits, while safety net programs are only available to low-income populations. Public option models like those in Colorado and Washington provide lower-cost alternatives to commercial insurance, designed to lower premiums, increase competition, and keep provider networks intact. In states like Colorado and Washington, the government works with insurance companies to create special, low-cost plans. These plans are designed to be cheaper for families while still making sure there are plenty of doctors available to see patients. Imagine you are at a school book fair. There are a few big companies selling books for $20 each. The school decides to set up its own table selling high-quality books for $15. Because the school's public option table is there, the other companies might lower their prices to $17 to stay competitive. In the end, students get cheaper books, and there are more places to buy them. Workforce models that reduce burnout. Team-based care models reward care coordination and outcomes, not volume. Instead of paying doctors for how many patients they rush through the door, these plans pay teams to work together to keep people healthy. This allows doctors to share their work with others, like counselors or health assistants. I've discussed many of these in previous podcasts. Here's what Reimagine Healthcare is working toward. We're trying to create viable alternatives that preserve access, reduce burnout, and offer coverage that feels real for the working middle. That means advocating for administrative simplification and payment reform that makes traditional practice sustainable. Supporting middle-tier coverage options so working families aren't squeezed out. Helping employers understand how benefit design affects whether employees can access care. Promoting hybrid models that blend cash and traditional payment streams. We're also documenting what's happening locally. When primary care providers leave insurance networks in Jackson County, we want to track the impact on access, wait times, and unmet need. That data informs advocacy and helps us understand where intervention is most needed. The shift toward cash pay and DPC is not inherently negative. It reflects clinicians adapting to system dysfunction and patients seeking more predictable access. But as a system-wide force, it has implications that extend beyond individual practices. The core question policymakers must answer is not, should cash pay care exist? It is, how many people must be priced out before the system intervenes? For the working middle, cash pay care is often a rational response to limited options. For the system, it's a warning light, not a solution. The growth of cash pay medicine is already creating a three-tiered system. Tier 1, patients with liquidity, access high-touch, efficient primary care, and patients on Medicaid have access to affordable care. Tier 2, insured middle-class families with high deductibles delay care and rely on safety net providers. Tier 3, high net worth individuals have the best of both worlds. This stratification imposes broader systemic costs, greater uncompensated care burdens on hospitals, higher acuity and costs for delayed care, fragmented continuity for patients with complex health needs. Slowing cash pay expansion won't look like reversing the trend. It will look like creating viable alternatives that preserve access, reduce burnout, and offer coverage that feels real. Combining reforms at payment, administrative, and coverage design levels creates a system where clinicians can stay in networks, patients can access care without undue financial strain, and the underlying drivers of cash pay exit lose their force. For Southern Oregon, this matters. We already have workforce shortages, geographic barriers, and capacity constraints. If cash pay expansion accelerates provider exit from insurance networks, those who can't afford membership fees will face even longer waits and reduced access. Safety net providers will face increased demand without proportional resources. The rise of cash pay healthcare is a market signal. It tells us the current system isn't working for providers or for a growing segment of patients. The question is whether we respond to that signal with structural reforms that address root causes or whether we accept stratification as the new normal. Before we wrap up, the usual disclaimer. This podcast is for educational purposes only, not medical advice. I've done my best to verify the statistics and policy details, but this is complex terrain and I might get something wrong. If you catch errors or have additional perspective, please comment and correct me. If these conversations are valuable to you, subscribe to our newsletter at reimagine-healthcare.org. That's where we go deeper on local healthcare issues and build community around making Southern Oregon's system work better. Thanks for listening. I hope you'll join me next week.